Next, we move on to HSV endothelitis, all that you need to know, to be presented by Dr. Niket Gandhi.
So, very good morning, all of you. At the outset, I would like to thank the scientific committee as well as Dr. Vikas for giving me an opportunity to present on this topic in the All India. So, my topic today is HSV endothelitis, all that you need to know. Now, again, inflammation of the corneal endothelium is something which we don't see very often, but then when we do see it, it's a very unique picture. In this case, we see that the endothelium function is disrupted and it can cause subsequent visual changes as well. And we do see a stromal edema without any very enhanced stromal infiltrate. The three main clinical features in a very simplified and a very basic version of endothelitis would be the KPs, which we see, the corneal edema, and the iritis, which is seen in many of these cases. So the etiology is quite varied, except for HSV. The other common viral infections in these cases are VZV, CMV. It can be any medication related. It can be one of the differential diagnoses is fungal and fungal keratitis, and other cases like venom can cause this type of clinical picture. It does, in few of the cases, we do see that it occurs in isolation, but in many of the cases, it does occur with interstitial keratitis, iritis, and trabeculitis. Now, again, the immune inflammation or the immune endothelitis is due to the cellular immune attacks on the endothelial cells. And once they are in the outer membranes marked with the HSV antigens, the immune attacks are exerted by the immune cells floating in the aqueous humor, and they are the primed immune cells to which the endothelial cell membranes is attached on. So there is no direct vascular contribution for immune endothelitis. Now, the stark features which we see the difference between endothelitis and the stromal keratitis is that the target of inflammation is endothelium. KPs are in a very primary and initial infection. We see that the KPs are under the area of edema only, and the non-edematous cornea is not really affected. However, in very few cases, we do see that there is intractable corneal edema, which may require further intervention. Now, in a study by Helena et al., they did study the endothelial environment in HSV, and in vivo confocal microscopy, they saw very distinctive changes like pseudoguttate and enlarged intracellular gaps, as well as infiltration of the inflammatory cells into the endothelial layer. There is also a loss of defined cell boundaries and endothelial denudation. So there is a specific attack against these endothelial cells, and we see distinctive changes because of them. Now, coming on to the classification of HSV endothelitis, the three usual classification which we see in the textbooks are the disciform keratitis, the diffuse endothelial keratitis, and the linear endothelial keratitis. Coming on to a very unique kind of a clinical picture is the disciform endothelitis. In these cases, we do see photophobia, limbal injection, and iritis, and there is obviously a reduced visual acuity because of the presence of the location of the lesion. And again, the edema can be central or paracentral, and the haze is typically very ground glass in appearance, and the KPs again are just behind the stromal edema. And in few of the cases, due to the presence of trabeculitis, there can be elevated IOP as well. Now, treatment in these cases is exquisitely sensitive to topical corticosteroids. There is complete resolution if treated early of the edema and the KPs, and you can see in a few weeks the patient goes back to normal. There can be the resolution is without stromal scarring, and in few of the cases it can be again self-limited, but in severe cases we do find permanent edema, scarring, and the neovascularization if untreated. Now, the same study which was mentioned earlier shows the endothelial cells which were affected in cases of HSV endothelitis before the treatment and after the treatment. You can see how beautifully the endothelial cells have resolved back to normal, and this is where we come to know that treatment, if early in these cases, do result in beautiful resolution of the disease. Again, the next very unique scenario which we see is a linear endothelitis. Now you can see, like any keratitis, they do present with pain, photophobia, and injection. However, clinically we see a line of KPs which are on the corneal endothelium, and they progress towards centrally from the limbus. Now again, peripheral stromal and epithelial edema between the KP is seen, and the non-involved cornea is again devoid of any KPs or edema. In a beautiful case report by Ashwin et al., they saw the presence of herpes simplex linear endothelitis in a post-keratoplasty patient, and we can see how the KPs are starting from the host cornea and going on to the graft, and a distinct area of KPs are seen and underlying endothelitis along with the stromal edema as well. Now, one scary type of endothelitis is something which you see in this clinical picture is diffuse endothelial keratitis. The unique feature about this is the retrocorneal plaques which are seen and the scattered KPs all over the cornea, diffuse stromal edema, and severe iritis. Now, a report by Todokoro et al., they saw similar cases where they saw deep stromal or endothelial infiltrate with feathery margins, and like any other clinician, they suspected fungal keratitis in these cases. They did their due diligence. They started the patient on antifungal medications, and they scraped the patients. And since the resolution was not seen, they went ahead and did a aqueous humor tap in these cases, and they did find the presence of HSV. And the patients were subsequently treated on oral ACVs as well as topical steroids in a very controlled manner, and you can see that in this type of clinical scenario, you do see resolutions. So disciform and diffuse endothelial keratitis do need oral ACVs and topical corticosteroids. However, in linear endothelitis, it can be stubborn at times, and even oral corticosteroids can also be required. My take-home message from this particular presentation is that early diagnosed endothelial keratitis can be treated with topical steroids with excellent outcomes and very minimal recurrences. Again, differential diagnosis of HSV endothelitis needs to be considered in cases of retrocorneal plaques. And it is important to understand that you need to do your due diligence when you are suspecting HSV endothelitis, and do rule out other scary infections like fungal keratitis in these cases. And there is a definite role of RT-PCR of aqueous humor in cases of suspicious infections. Thank you.
Thank you, Dr. Niket. So just to add 2 points here for HSV endothelitis, it is important to differentiate from immune stromal keratitis, number one, and the key to differentiation is that the edema is disproportionate to the stromal inflammation in endothelitis, and that is where you differentiate it from immune stromal keratitis. Immune stromal keratitis may have mild edema. Endothelitis will always present with disproportionately more edema as compared to the stromal inflammation. And important to differentiate because endothelitis requires oral acyclovir only, and topical acyclovir will not work in endothelitis as a prophylactic that we give in immune stromal keratitis. So oral acyclovir is a must for endothelitis patients versus immune stromal keratitis.
Just to add on to that, the very distinctive slit lamp examination in these cases is where you have a slit beam on the clinical picture, and you see cellularity on the posterior stroma as compared to a frank infiltrate. And this is where you can distinctively say that this is mostly endothelitis rather than